Hello, everyone. Good morning, good afternoon, good evening, wherever you're joining us in the world. I am Rahel Nardos, Associate Professor of the Division of Female Pelvic Medicine and Reconstructive Surgery, and the Director of Global Women's Health at the Center for Global Health and Social Responsibility at the University of Minnesota. And I'm also a board member of Worldwide Fistula Fund. I will be moderating today's webinar, and we are so excited to welcome you to this event today entitled The Power of Personal Stories and Communities to Reduce Disparities in Global Maternal Health. Today's event is part of our university's webinar series celebrating International Women's Day, which was earlier this week on Tuesday, March 8th. We have an excellent panel discussion for you today, and we also have a pre-recorded message from Representative Ilhan Omar, which we will share in a bit. As we hear from our speakers today, please submit any questions that you have using the Q&A function at the bottom of your screen. The chat function is disabled, so you cannot use that. This is a 1.5 hour program, and we will leave the last half hour for your questions. So we really hope that you stick around for the full program. Before we begin, I like to share with you some of the great collaborative work that we're doing at the university related to the global women's health. First off, this webinar series is hosted by a collaborative of multiple centers and units at the University of Minnesota, as well as external collaborators. These centers are part of our ongoing work group called WHEEL. WHEEL stands for Women's Health Equity, Empowerment, and Leadership. And this group hosts webinars and other activities related to the intersection of global women's health with policy, human rights, and culture, among others. So in addition, at our Center for Global Health and Social Responsibility, we are proud to have a variety of events and activities in education, research, capacity building, and other areas. I want to highlight that we recently launched a new global health engagement funding mechanism at our center, and we are really pleased to support 2 great women's health projects this year, which I hope you can see on the slide here. Later this year, we plan to host a series of researcher spotlight events with our grant recipients as part of the center's Global Health Day. So we hope that you will stay tuned for more information on that. And now to the topic of today's panel discussion entitled The Power of Personal Stories and Communities to Reduce Disparities in Global Maternal Health. So why is it important to talk about maternal health in a global context? Globally, approximately 830 women die every single day from preventable pregnancy and childbirth related causes, and approximately 94% of this occur in low and lower income countries. In 2000, the UN Millennium Development Goal was initiated, and number 5 on the list of these goals was to decrease maternal mortality by 75% between 1990 and 2015. So during this time, there was a 44% decline. But despite this, for example, in sub-Saharan Africa, a woman's lifetime risk of pregnancy and childbirth related death is 1 in 36 compared to 1 in 4,900 in some high income countries. So there's a huge disparity. And I'm not even talking about the many more maternal morbidities where a mother may survive but suffers grave physical and psychological consequences, as you will hear today from some of our panelists. But even in high-income countries like the US, there are great disparities in maternal outcomes. Pregnancy-related death for Black and American, Indian, and Alaskan Native women is 2 to 3 times higher than white women. And this is very much true in our own state of Minnesota. So as a society, we simply cannot afford not to make maternal health our number one priority in our national and international discourse when we talk about health, politics, the economy, society, and even the environment. Because let's be honest, none of us would be here if our mothers did not carry us safely through pregnancy and childbirth. Hence the African proverb, the hand that rocks the cradle rules the nation and its destiny. So we are thrilled today to have opening remarks from Representative Ilhan Omar. Unfortunately, her schedule changed and she's not able to join live today, but she's prepared a pre-recorded remarks for us to share. Representative Ilhan Omar represents Minnesota's 5th Congressional District in the U.S. House of Representatives, which includes Minneapolis and the surrounding suburbs, and that's my district. An experienced Twin City policy analyst, organizer, public speaker, and advocate, Representative Ilhan Omar was sworn into office in January of 2019, making her the first African refugee to become a member of Congress, the first woman of color to represent Minnesota, and one of the first 2 Muslim American women elected to Congress. Congresswoman Omar is a member of the House Foreign Affairs Committee, where she serves as the vice chair of the Subcommittee on Africa, Global Health, Global Human Rights, and International Organizations, among other roles. And with that, her message.
Hello, everyone. I want to start by thanking Dr. Nardos and the Center of Global Health and Social Responsibility for the invitation and for organizing this great event. It is an honor to open today's program in celebration of International Women's Day. This day is an important marker of how far we have come in the global fight for gender equity and how far we have left to go. In the spirit of today's discussion about the power of stories to reduce disparities, Day special significance for me personally. Today marks the anniversary of the day I arrived in the United States as a refugee. My story is the foundation of the work I do every day to fight for human rights, including health, both here and abroad. My story is why I'm a founding member of the Black Maternal Health Caucus and an original co-sponsor of the caucus's landmark Momnibus package, which would address America's shameful racial disparities in birth outcomes. It is why, in my first year in Congress, I hosted a panel with some of my districts and the country's foremost experts on Black maternal health. It brought me to serve as the vice chair of the Foreign Affairs Subcommittee on Africa, Global Health, and Global Human Rights, which gives me added insight into the United States international aid and foreign policy on the continent. The United States has vast opportunity to improve global health, and we do, but we have largely operated in the same way for decades, giving to the same organizations using the same mechanisms with the same outcomes. I have never been concerned with doing things the way they have always been done, and this work is no exception. In my leadership role on the subcommittee, I push for change to bring new ideas, facilitate new connections, to maximize our impact, to improve the health of women and girls around the world. These new ideas and connections are where your work and the work of today's amazing panelists are critical to informing my work in Congress. By calling upon the expertise in my district, like from Dr. Nerdos and the Center for Global Health and Social Responsibility, we can push together for this much needed and long overdue change. I'm inspired every day by my daughters and the powerful women around me to build a more equitable world for future generations. I strive to ensure that women and girls around the world have free and equal opportunity to be healthy and to create their own stories. Wishing you all happy International Women's Day. Thank you and God bless.
Thank you, Representative Omar, for such a wonderful message. And we are so fortunate to have such an advocate of maternal health and equity in women's health right here in our town. And now I'm honored to introduce our panelists. I will start with Dr. Marianne Etibet. Dr. Etibet has over 2 decades of experience improving health outcomes for underserved populations and transforming healthcare delivery at the front lines. She serves as AVP for health equity at Merck, where she's responsible for driving an enterprise-wide health equity strategy for the company and delivers on sustainable business and societal value. She also serves as lead of Merck for Mothers, Merck's $500 million global health initiative to help create a world where no woman has to die giving birth. Since 2011, Merck for Mothers programs and partnerships have supported safe, high quality and respectful maternal care for over 13 million women in 50 different countries. Welcome, Dr. Marianne Etibet. And second, we have Sarah Omega. Sarah is the founder and executive director of Let's End Fistula Initiative, or LEFI in short. Her passion to advocate for women living with fistula started in 2007 following a successful surgical treatment that ended her 12 years of living with obstetric fistula. Sarah has served in a number of influential roles, including Kenya's maternal health advocate under UNFPA Kenya office, the treasurer of the board of Gynecare Women's and Fistula Hospital in Kenya, and a board member of the Fistula Foundation. Sarah is also one of our Worldwide Fistula Fund partners. So welcome, Sarah. We're so happy to have you. Our fourth panel, our third panelist, who is not joined here yet, but hopefully will, is Alice Emasu. Alice is the founder and executive director of Terawude and Terawude Women's Community Hospital. She brings to Terawude over 19 years of experience in leadership, management, and programming, and her passion for gender equality and social justice is the driving force for unlocking the healthcare and economic systems that disempower women and girl child. So Alice is an outstanding social entrepreneur holding a Master of Social Work from Washington University in St. Louis, a Master in Business Administration from University of Cattolica in Italy, a Bachelor of Arts from Makerere University in Uganda, and a diploma in development journalism from the Indian Institute of Mass Communication in New Delhi. So Alice is also one of our Worldwide Fistula partners. She's having some connection issues currently, but I hope she'll join us and we will see her soon. So let me start with before we start actually talking to our panelists, we have a quick fun activity for our audience that hopefully we can get you engaged. It will be, we have a couple of interactive questions that we are going to ask you, the audience, to respond to, and they're related to our theme today of maternal health. So they will get us thinking about the context of maternal health around the world. And the questions will be shown, and we want you to answer them as fast as you can. And then we will discuss the answers in just a little bit. All right, as you can see here, the majority of you actually got this right, 48%. So that means you were listening to me when I was giving you the answer to this one.
It's the professor and you coming out.
All right. So the answer to this one is actually 94%. Most of you guessed 85%. I know it's pretty shocking, right? That such a huge number of maternal deaths are happening in low and lower income countries. And this is, most of this maternal deaths are actually preventable. And the reason why they're happening in those settings is because of lack of access to quality obstetric care. So we could reduce this disparity greatly by putting in place the things that we already know are successful in higher income countries. This one was a trick question. Most of you did not fall for the trick, but some of you did. So I think we all have a close relationship with someone who has had a baby, right? Our moms. Otherwise, we wouldn't be here. This is actually kind of to demonstrate that the cause of maternal health and caring about maternal health is everyone's business because we're all impacted by it. So this was fun. Thank you so much for taking part in it. And I hope you found it really exciting and interesting. And it will help you tune into the conversation that we're about to have following this. So now let's begin with our conversation with the panelists. My first question is for Sarah. So Sarah, I've always been so inspired by you, and I'm really, really excited that you're here. And it looks like Alice is finally joining us as well. Wonderful. So Sarah, we often talk about large disparities in maternal health in abstract terms, right? At the level of populations, which has, the tendency to either overwhelm us because it's just too much and we don't know where to start, or to detach us from those who are suffering on a one-on-one basis. But stories of individuals like yours have the power to move us to action in a way that statistics never will. So tell us briefly your own personal story that has led you to your work as a founder of Let's End Fistula Initiative. And again, really appreciate you being here and sharing your story.
Thank you so much, Dr. Ryle, the Center of Global Health and Social Responsibility for making it possible for me to be here your morning, my evening, to share my story that I believe has impacted the world in a positive way. I'll not go back into introducing myself because I've already, thank you so much for that beautiful introduction. I'll just dive directly into my story. That at the age of 19, I got pregnant, resulting from rape. Even with, both, I would say, physical, emotional, and the psychological trauma, I managed to carry my pregnancy to full term. But when it came to time to deliver my baby, I experienced a difficult labor that lasted for over 48 hours. But later I delivered through cesarean section to a stillborn baby boy who weighed about 10.6 pounds. And 3 days following the cesarean section, while I was still in the postnatal ward, I realized that I was different from other patients because I would wake up and find my bed wet, unlike other patients in the same ward. When I raised the concern after physical examination, it was confirmed that I had developed obstetric fistula. Of course, I didn't know what it was. I actually remained hospitalized for 2 months, then later discharged with the message of hopelessness, that it would only take a doctor from abroad to treat my condition. And that actually meant in my world that treatment was impossible. I went home and life was never the same again. I suffered physical pain resulting from genital source. I suffered emotional and psychological pain resulting from humiliation that I had to face every single day. Before I was isolated, I would isolate myself because of the bad odor. I always felt trapped. I couldn't go out. I lost my friends. For me, life was a punishment. Being alive was a punishment. And unfortunately, I live with this kind of pain whereby you are unable to control urine. You are leaking urine 24/7. And I lived with this condition for 12 years. It is until in 2007 when the stigma that is attached to the condition sent me into depression. The depression that landed me in a psychiatric ward. And as I was undergoing treatment for depression, I learned that fistula treatment was possible in the same facility. So in May, the same year, 2007, I underwent a successful corrective surgery that ended my 12 years of living with obstetric fistula. And through my interaction with medical personnel, I learned that I was just but part of a huge statistics of women living with fistula in my country and other developing countries. This understanding, having gone through the pain, having known how you are treated as a social outcast, this knowledge pushed me into action. And I made a decision, as much as I wasn't without any medical background, that is my studies. I chose to use my story to bring about hope. I chose to use my voice. And that is how I informally founded Let's End Fistula Initiative as my personal mission to find and link fistula patients with fistula treatment opportunities, which over 10 years, it has continued to evolve through the programs that we've carefully developed, programs that have not only helped fistula patients to access fistula treatment, but it has gone an extra mile in developing very influential leaders from fistula survivors who've continued to impact their respective communities using their personal stories, who've continued to change the story, who've continued to correct the mistakes that our forefathers or the people who came before us left, using their personal stories. And at LEFU, for over 10 years, our goal has been ensuring that motherhood is something to be celebrated. we've combined our voices, we've used our stories to making motherhood safe for every woman. Yeah, thank you so much.
Wow, Sarah, you know, every time I hear your story, and I have known you for a long time, it's just not only, you know, it's one of those things that breaks your heart that such a thing still happens in this world, that we should not, mothers should never have to go through what you went through. But at the same time, it is incredibly uplifting and inspiring to see you own your story, share your story publicly, leverage your story to inspire communities, empower communities, and really, you know, elevate people. And it's just incredible. And you give us hope, and it makes us want to do so much more with you. So thank you so much for that, for being here. And Alice, I'm so glad that you're here today and you were able to make it on this connection. Sorry you had some challenges. I already introduced you without your presence. So as we've just heard from Sarah, our own lived experiences are often the fuel, right, for the hard but important work that we do. And I also want you to tell us a little bit about your own personal story.
Hi, our viewers. Yes, I had a bit of challenges, but I'm glad to be part of this wonderful platform, giving us an opportunity to share and raise the voices of the voiceless women and girls in our various communities. Actually, my story started with that first moment when my excitement, would have been exciting moments turned into sadness. After I went in search of my former girlfriends, the girlfriends who were much older than me, but we were living in the same village. We were raised in the same rural village. They were my role models, and I looked up to them. I knew that out of them, some of them were going to become midwives. Others were going to become doctors. Those were our dreams, you know, as they used to inspire me. So this particular time, I happened to be going back to the village to reconnect with them, excited. And upon inquiring from about each one of them, the story changed. The happy moments changed. Out of the 6 of these former girlfriends of mine, 2 of them had suffered a fistula. But the unfortunate thing here is that nobody in the village, even the elite that I would meet and inquire about what could have happened to these ladies, understood what a obstetric fistula was. 4 of those teenage girlfriends of mine perished due to preventable complications of pregnancy and childbirth. I felt challenged. Sleepless nights. I worried. What worried me more was not necessarily the fact that these girls, I could not find them. But what was so saddening was the fact that the community could not find answers to the whereabouts of these girls. And they were living like it's a fate. This is the fate of the women in our community. We have got nothing to do about it. They felt helpless. They felt disempowered. I woke up to this challenge. I felt I could do something. Remember that time I was still a student on vacation. I said, but how could people live like this? And so in search of questions, why these girls, by then I hadn't even seen the ones who had ended up with a fistula. But the description in the society was that your two friends ran mad. I think because of the dirty life they live. Women are dirty. Now, this dirtiness was being associated with women who are in menstruation period, and they simply do not know how to protect themselves, how to care for themselves. And then the other ones who perished, that was also being blamed on them. Okay, they went into relationship prematurely. They were rebels because they felt they were educated. They were badly behaved. So these are the things that kept me thinking, and in search of those solutions and the answers, I ended up prematurely into the media industry. I wanted to tell the stories of these ladies. I didn't know the exact cause of their situation. And I felt the media was the only way that could help me. And I started doing my search about this. And I realized that these girls were among the 505,000 women that die annually. 105 per 100,000 women who die annually in Uganda. By then, this was over 20 years ago, due to those complications of childbirth. And there was nothing really very serious to deal with them. So I thought, I can't wait, I have to do something. Can I start by raising awareness? And that is actually the core and the pillar of Terewode, the not-for-profit organization that I founded legally in 2001, creating awareness about maternal health, about the plight of the most vulnerable, the rural women, about obstetric fistula. And with the coming of Terewode, it then became more clear that there were 200,000, these are research estimates, but these are the national figures we have, 200,000 case backlog of obstetric fistula, women who are living with fistula. But what was challenging then was that there was stigma surrounding this whole thing. Nobody needed to talk about it. And the capacity to provide care for these patients was lacking. I was called a rebel, I was called the names, I was called a mad girl when I started a campaign to raise awareness and mobilize over 300 of these patients in a small community where currently I have established a dedicated fistula hospital in Soroti. That's the community where I began this campaign. Terewode Women's Community Hospital is specialized. It's providing routine care, and it is focused on helping women who are unfortunate. Yet again, at the same time, they survive the death because they are the ones that are giving Terewode, that are informing my interventions, because they tell their stories. And from their stories, we have designed a holistic approach to dealing with this problem. So Terewode Women's Community Hospital was launched in 2019, and it is providing care to, it has a capacity to provide care to 600 women and girls with fistula annually. But prior to the commissioning of this specialized hospital, I had dedicated a lot of my energy supporting the care, mobilizing, doing advocacy, getting the ministry on board to support these ladies to receive care. To the extent that as of today, I can say and confidently so, that there is some level of leadership that the government of Uganda is providing in the campaign to end obstetric fistula and improve maternal and child health in the country. Why there are some policies that can be enforced. The other significant impact of this work that I started as a teenager, and now I am aging in this work, but I can look back and say, yes, there is a significant level of awareness growing in Uganda in most communities. There is now a term. Then my focus was, can obstetric fistula become a term? Can it be a domestic item, a word that every household is familiar with? Breaking the norms, breaking those barriers, those cultural barriers of issues of sexuality can never be raised in public. It's a taboo. But here I was then, 20 years ago, saying, yes, we must make obstetric fistula a domestic item. And I say, yes, we have achieved to a larger extent. There is still a lot much more to be done, but we have some hope that we shall make it.
Thank you so much,
A
Alice.
routine, very good.
Thank you so
Thank you.
much, Alice. I would give you another opportunity in the follow-up questions. I just want to make sure we use our time. But you know, Alice, I remember when you showed me the sketches for your hospital that was built in, you know, that I don't remember how many years ago you were in Portland with me, and in my kitchen table, I remember you showing me the sketches of the hospital and your vision to build this hospital after doing so many years of work in fistula reintegration in the community. And I am just so incredibly inspired at what you've been able to achieve. Thank you so much for sharing your story. I am going to turn to Dr. Tibet. Marianne, you and I go way back to medical school days, and you know, I blinked my eyes for 18 years or so and found out that on Twitter one day that you were directing the Merck for Mothers program, and I am not surprised. I was hoping maybe you can share with us today how, you know, your own lived experience has led you to the work that you're doing to bring equity to maternal health.
No, thank you so much, Rahel. I too am not surprised, and I just really thank you for bringing me into this community of amazing women leaders. You know, Sarah, Alice, just thank you so much for sharing your stories, but thank you, you know, for that bravery, for that resoluteness of, you know, just pushing forward, you know, with your visions, with your leadership. You know, it's changing lives. And I love the, you know, title, Rahel, that you said, you know, that sharing of stories. How do we raise those voices? How do we make the invisible visible? How do we make the silent, you know, loud? And one of the things I think that we've learned as an initiative at Merck for Mothers is, unless you are, and I say this all the time, it's not enough just to listen. You know, it's not enough just to elevate or amplify the voices. You have to respond, you have to act on what you're hearing, and then you have to hold yourself accountable. And I think as a global health community, we are at different places, you know, on that journey. But Sarah and Alice, you know, I do think, you know, your example and your stories and the stories that you're also surfacing, you know, will get us there faster. So just thank you so much for that. Rahel, you asked me about, you know, my journey. I'm, you know, from Nigeria, born and bred, and Nigeria is actually the country that has the most maternal deaths in the world, 20%, you know, of the maternal mortality burden. And I, you know, growing up, you know, every week, every month, you would hear some story of somebody dying in childbirth, your family member, a friend, an employee, someone working with my parents. And I remember thinking, what is going on? That was that understanding of giving birth and childbirth, that there was a very large chance. And in fact, now it's a 1 in 43 chance, if you're in a low middle income country, that you will die during childbirth. And I think that, seeing the inequities, in healthcare access and healthcare outcomes when I was growing up, informed that journey. And, we went, we saw some of that solution as being a clinician, being a medical provider, as Alice said, that is essential, in so many cases. But I think what also spoke to me was recognizing, and both Alice and Sarah talked about it, that your health, exists in a social, cultural, and economic context. And unless you are addressing those factors, the lives, you can't live optimal lives as women. And so one of the things that we are very cognizant of is, those, and, we use the term, the social determinants of health, which are kind of responsible for the 80% of healthcare outcomes. Those are the environments that we all live in, we work in, we play in, we get educated in, and they really impact, our health outcomes. And so, as I was going through my journey of becoming a physician and actually practicing as a physician, I was always cognizant that I also needed to work, in that broader space, of policy and systemic action, helping to strengthen health systems, helping to make sure that the work was being integrated with leaders in the community, such as Alice and Sarah. And not the least, we are, on the heels of International Women's Day. This is, Women's Month. Every month should be Women's Month, but it's a chance for everybody to talk about this. We're not going to get to, you mentioned we're only about halfway to goal. And in fact, the COVID pandemic in the lower middle income countries, we need to move 10 times as fast, to get to those targets. But we're not going to get there if half of the population is disempowered and disenfranchised, and subject to all of those stigmatizing behaviors in the communities that they live in. And so it's my belief that unless women are fully integrated, women like Alice and Sarah, fully integrated into designing these solutions, leading these solutions, we're not going to get to goal. You mentioned, the hand that rocks the cradle rules the nation, and shapes our destiny. I actually did a quick Google search. 1 in 54 African lead presidents right now is a woman. So, we're not living up to that saying. She's from Ethiopia, so you should be proud. But as a continent, 70% of the healthcare workers are women. Only 25% are leaders, and so we need to figure out how to continue to identify ways for improving gender equity, because it's at that intersection of gender equity and all of the other inequities that we see in our society that impact the lives and health of women. I think the other thing that I wanted to say, and this is something that happens across the globe. In the United States, we see those healthcare disparities also happening. When we invest in women, and when women are fully integrated in our solutions, that's when I think we will see that reduction in the inequities. I was very struck also, Sarah and Alice, by your stories. And I think it bears reinforcing that unless these stories are systematically integrated into the structures and systems and policies of the work that we do, they're just stories, and they shouldn't be just stories. And so that's a lot of what Merck for Mothers tries to do. So for example, one of the mechanisms of holding ourselves accountable for maternal deaths is to do maternal death reviews and have maternal death committees that investigate, the deaths that are happening. But what we found, first of all, in the US, that the only people on these committees were the healthcare workers in the facility. It didn't include women with lived experiences or their family members or community members. So all of that experience outside the four walls of the community was not heard and did not influence the findings, did not influence the recommendations. And so we've done a lot of work to systematically make sure that those voices are standard. This should be a standard. This should be, a requirement. And it's great that we've seen, that policy, really being replicated in multiple states in the United States. In Nigeria, for example, 60% of the births are happening outside of the facility. And so if you only limit listening to the facility, you're missing out on 60% of what may be happening. And I want to just share one quote, because we did similar work in Nigeria where we collaborated with an organization, Nigeria Health Watch, where they held actually community-based, kind of maternal mortality reviews and had everyone in the community come together and share why women were dying. And the findings that were around, Alice, to your point, lots of cultural beliefs that to be shown to be a strong woman, you have to give birth, at home. Going to facilities is a sign of weakness. There was an experience reported of, from a woman in Nigeria and Lagos, where she was giving birth in a faith-based facility, that did not meet, clinical, quality health standards. And the reason that her family wanted her or made her give birth in a faith-based, facility instead of a, hospital that had high quality care is because her older sister had died during birth. And the reason people felt that she died was because of, her quote unquote infidelity. And that, that history of, quote unquote infidelity, was this, her death was that spiritual consequence of that. And so, her younger sister now had to give birth in a faith-based facility. So I don't want to underestimate that unless we really, as Rahel said, elevate these stories, but more importantly, institutionalize them, we're not going to get to the heart of the problem. And that's what we need to do, in order to save lives.
Thank you so much, Marianne. And actually, you sort of answered the second question I was going to ask you, in terms of how to be more impactful. And one of the ways, it sounds like, where you highlighted integrating the stories into the policies and into the work that we do by bringing those voices into our meeting rooms and planning rooms. And I think that needs to happen a lot more than it's happening right now.
Yeah.
So my second question for you, maybe we can just start with you, was how do you have any other, maybe in 1 or 2 minutes, if you can tell us ways to synergize all these different efforts? Because one of the things I noticed with maternal health is that there are funding organizations that are trying to tackle this. There are a lot of academic institutions. There are community activists and champions like Sarah and Alice, but there's not as much synergy a lot of times. And, as an academic institution here who are trying to engage with communities and funding organizations, are there any good examples of platforms we should explore where we can actually synergize?
I'm so glad you asked the question. And I do think we have a responsibility, as a funder, to actually look at our processes and policies and systems to see if they're actually exacerbating these inequities and we're actually wasting resources because, as you said, we're not working together. And I think, you know, I don't know if this has been your experience, Sarah and Alice, but you know, the way that the funding system, philanthropy, global health development is set up, it's very top down. You know, it's very, you know, quote unquote experts, you know, identifying what the solution is, and then, you know, funding, you know, different organizations, oftentimes international organizations, you know, to implement the solutions. And I found, you know, that it actually creates, you know, incentives for competition, you know, on ground between the, you know, different organizations, whether they be community-based organizations or civil society institutions who are competing, you know, for these funding. We, Sarah, your head is shaking. We need to change that. And so one of the things that we've done recently is launch a initiative called Strengthening Systems for Safer Childbirth. We did similar in the US, which we called our Safer Childbirth Cities Initiative, where we were explicit that we wanted proposals from coalitions, and coalitions that were community-led, locally led, and that we wanted to see how these coalitions would think about integrating local strengths, local contributions, whether they were from the private sector or from the communities, you know, or otherwise, and how do you do that integration on ground? Because when women are seeking care and going from one point of service to the other, that system has to be, you know, integrated for the woman. She, you know, it doesn't matter, you know, where it's coming from, and not any one entity can meet all of her holistic, comprehensive needs. And so we'll see, you know, we've just started this, you know, I have a lot of optimism and hope for it, but we have to break down those structures and systems that actually are not allowing, you know, for community, you know, with all of the leaders that are advancing, you know, on these solutions. We don't have enough money, so we need to leverage all of the resources that we have, including local resources. The other thing I will say is we need to invest in people, and we need to think about this funding as investing in people. People are what is going to drive progress. People are what is going to ensure that whatever is happening is sustainable and lasts longer than the funding that you are providing. And I'll just give, you know, two quick examples. You know, one is around, you know, also the power of the private sector, because we need kind of sustainable models, you know, sustainable business model or financing models, you know, to again make sure this work happens. And so one of the things Work from Others does is invest in social entrepreneurs, so that they can, you know, grow, you know, their solutions in a sustainable way. Another thing, you know, we've done, and, you know, Alice, I thought about this collaboration, you know, when I learned more about your organization. Many people will remember or know that Northern Nigeria is oftentimes beset, you know, by terrorists, including one of the states in the Northeast, Borno. And at one point, you know, I guess 7 years ago now, kidnapped, you know, over 200 schoolgirls, and, you know, basically, you know, enslaved, sexually assaulted. Many came back pregnant, and we worked with an organization called Girl Child's Concern to work to reintegrate, you know, these girls into society through education. Our funding was specifically around training to be village health workers or community health workers, trained, you know, over 200, you know, of these village health workers. And, you know, from what we've learned, you know, that created this sense of self-esteem. You know, they now had really important roles in their societies. So the stigma that they had been facing, you know, they were able to work through it, you know, through this support and through the work that they were doing that was valued. We heard that, you know, because of the work that they were doing, more people were going to primary healthcare centers, you know, to get primary healthcare, to get their children vaccinated. And now that program has been adopted, you know, by a federal government program. You know, they were always being paid, but they continue to be paid, because that's the other thing, we need to pay, you know, our women healthcare workers, our community health workers. And, you know, back to your question, you know, we need to be working across sectors, you know, at the front lines to make these connections.
Wonderful. I mean, I'm sure, you know, I see Alice and Sarah shaking their heads. We actually recently started having conversations about creating a learning community through our Center for Global Health for all our fistula partners in 5 different countries, including Alice and Sarah, and Worldwide Fistula Fund, as well as our center. And the idea behind that, exactly what you were saying, Mariana, is number one, to kind of hear the voices of to create a space where they can actually talk to each other and synergize and share best practices and figure out ways to leverage each other's voices to advocate even at bigger scale, and also work on things like research and other things that would elevate women's health. So I'm really excited that funders potentially would be interested in something like that, that helps support local coalitions and synergies among these experts on the ground. We are running a little bit short on time, but I would really love to hear, maybe in 1 or 2 minutes each, Sarah and Alice, maybe we'll start with you, Sarah. Can you tell us a little bit about, you know, you've done some incredible work with empowering women, especially women with prior history of fistula, to really use their stories and their own personal journey to empower communities, to educate other women, and also economic empowerment models that you've created for them. And now you're starting to work with younger kids in schools to teach about safe pregnancy and childbirth, and you're just doing so many things. What I want to hear is, are there things that you feel would make you even more impactful? Like if you were to describe that in 1 or 2 minutes, what would help you be more impactful in the work that you're doing and make your works more scalable and more sustainable?
Yeah, thank you. I think at LEF, you know, our modeling has always been, you know, designing programs that actually get to the does not only deal with the fruit of a problem, but goes to, you know, dealing with the root cause of the problem. Mm-hmm. And you know, so I think going back to your question, I think sometimes funders, you find funders are really interested in numbers. And sometimes when you focus on numbers, sometimes it brings about unnecessary competition, like the number of people reached, the number of, you know, but for us, from where we are looking at things, is finding permanent or lasting solutions. And that's why you find that how we develop our programs is actually programs going to deal or to correct those mistakes, like, you know, like what we are doing with women in the communities. We may not really be able to count this number of women have been successfully reintegrated into their respective communities, or that this number of women have been reached. But what we are looking at is, you know, how do we change, you know, the theories around harmful cultural practices? How do we change, you know, the root causes of the problems you're talking about? And it actually means going back to the, you know, if we are actually talking about ending fistula, will mean going to the root cause. And sometimes that doesn't fit into the funding patterns or the funding needs. For instance, what we are doing, what we are doing with the young, the adolescent girls and boys in school, we're actually looking at, that the most vulnerable. And therefore, if they're not involved in this, they're not involved in finding solutions to the problems or the challenges that affect them. You find that, we'll actually be waiting for them, the other side of life, to come back with a fistula. But now you find that sometimes you don't know whether to really focus on, dealing with the issue or be busy with numbers. So I think really having conversations with people who are doing this important work in the communities, and also having a forum where we are able to engage, to share some of these insights that would actually inform how funding is prioritized, would be very critical. And again, just like having forums whereby, the same people are doing maybe this important work, are able, to come together, exchange ideas, talk to each other, learn from each other, would be a very important thing for us, because sometimes being the place of leadership, it's not always easy. You keep on thinking, what would, when you do this one program, it actually creates needs for more projects, it creates needs for needing to do more. Yes. And, just having a place whereby we are speaking the same language. I'll say something and Alice will say, I think I know what you're talking about, would be very, very helpful for us. Yes. And again, just, really investing, as Mariana already said, investing in people. We actually, we need to learn more. Yeah. In being the place of leadership it doesn't necessarily mean that now we are all knowing. It doesn't mean that we've stopped learning. The world, like she's just described, like how now funding is happening, happening in maybe in groups. Those are things, those are information, knowledge, that knowledge maybe like how to maximize, the social media page platforms, those are some of information, skills and knowledge would be very, very helpful to us. And the final again, for sometimes when here in Kenya, you're trying maybe to look for maybe some data, like maybe updated data around maternal health, and you can't find. Maybe you find that we are still using data that we've been using for the last 10 years. You find that kind of data might not be even helpful for us. People are designing programs, might not be helpful to us in terms of making decisions, in terms of how to prioritize resources, the little resources we have. And of course, money, funds is everything, we need this, we need funds to do this important work. We need funds to continue using the stories of women to transform the world and to correct the mistakes that were done, to change the story, to now share the story of hope. That would be my few suggestions on how we could maybe help in improving our work and helping in scaling up and out.
Thank you so much, Sarah. Such wise reflections on that. I mean, I can say a million things about what you just said, but in the interest of time, Alice, do you have anything to add to that? Anything more to what Sarah has just said in terms of elevating your impact?
Yes, I have two things to say about that. One of them, Terewode Women's Community Hospital does not only exist to clear the case backlog of fistula, because if we talk about clearing the case backlog, how recently in the last 2 years, again, we are seeing really fresh fistulas being formed. So when are we going to clear the case backlog? But what we are standing for is quality care. If a woman, for some reason, ended up with a birth injury, with a fistula, they should not wait for too long to access care. And this care should be provided to them with respect. They should experience dignity because it's not their fault that they got a fistula. And that is exactly what Terewode Women's Community Hospital stands for right now. So it is there to also learn and inform the government, especially our Ministry of Health, that it is possible to provide routine care for fistula. It is possible. It is an investment. It's achievable. So we are doing whatever it takes to see that what does it really, why is it that our countries adopted a camp-based approach in the care of obstetric fistula? Why? Is it because of cost? How expensive is it? So that's what Terewode Women's Hospital is really, really working to achieve. Giving the women a feeling of acceptance when they set their foot in the hospital. They feel accepted. They feel recognized as mothers, strong pillars of every nation. Can they have that experience? And so we find that putting a little bit more, going a little extra by getting them, providing for their welfare in terms of clothing, that's the start of feeling that I'm a dignified woman. Changing clothes, basic things of life like food, not during the time of treatment. The clinicians are only preoccupied by giving you medication, but you're going on an empty stomach. What does that mean? These are basic needs. And we are coming to experience that. We are piloting that to see it is possible for these poor women because they are coming from impoverished communities. They have been traumatized, they have been stigmatized. So that is something that we think we could combine efforts and make it work. The other one is getting our governments, calling our governments to take leadership. Yes, I know we are getting a significant number of women who are mothers into leadership positions of our countries. Mary Ann, you talked about having women now who are heads of states. Yes.
Only one.
Only one? Okay. Well, we shall work hard to get there. But the thing is, it should not just be women getting into positions of leadership. It should be women being conscious about the plight of other women, especially the most vulnerable. So can they begin to influence the resource allocations to these things that matter so dearly to the hearts of women like Alice, Sarah, Rahel, Marianne, Anna, all of us who are here today. We want to see significant resources allocated to address maternal health and eliminate obstetric fistula. But I also just want to re-echo what the Mariana and the Sarah talked about. Really, we have to build alliances, even right from communities. Right now, for us in Terewode, for me to be more impactful, I need to get these fistula solidarity groups, these community solidarity groups empowered, okay, and provided with platforms where they can engage effectively to cause the desired change, which we want. And what is our desired change? No woman dying from preventable pregnancy and childbirth. We are tired of that. Those statistics should become history in our countries.
Amen, Alice. Amen. We all believe in that. And oh my gosh, you know, this has been such an inspiring conversation. We could have done a 3-hour panel today. Actually, you brought up something at the end, which is also brought up in the question. I'm going to switch to the Q&A now to give our audience at least 10, 15 minutes to respond to their questions. Again, I really appreciate you guys being here and appreciate the audience. The question of leadership you brought, Alice, also, and I was gonna maybe pose this to Marianne. The question was, what would be the best way to encourage more female leaders? And also as part of that, is there an improvement of women's birth health outcomes when there are female physicians and female leaders? Yeah. And I think Alice did mention it's not just about having women in leadership position, but also empowering them to be influential and impactful. Yeah. Do you have, I mean, I think leadership has always been near and dear in my heart in terms of, aside from education, education, young education, youth education, the next thing is leadership to move the needle on this. What are your thoughts on this?
So great question. I'll answer the second half first. Around is there data and evidence that having more female healthcare workers, physicians makes a difference? And I would say yes. In communities, all across Nigeria, there are many instances where women are not allowed to see male doctors or physicians or healthcare workers. And so just the fact that that in and of itself, is a barrier. And we see that in many different communities. Again, how social cultural beliefs and norms really impact the ability to access care, depending on who may be giving it. I'd like to come back to this notion of leadership and alliances and this community, community of practice, community of purpose, community of action. And it's not about putting, it's not about thinking that one person, is going to make the difference. But the power of that person, as well as all the other people he or she brings to the table to make those really important resource decisions, to change policy, structures, processes, institutions. That is what's going to have that amplifying ripple effect, because then you're not making change one by one. The one change that you have now goes out and has dividends of change. And I think that we have to, I always say the means can be the end. At the end of the day, we want gender equity. Okay, the way we work needs to actually reflect and incentivize gender equity. It's only by changing the way we work that we're actually going to get the result. And so, what I would say is that we need to be conscious and intentional. And even I'll say in our initiative, we went through a process of holding the mirror up to ourselves and saying, are we really walking the talk, about putting women's voices, at the center of everything we do? And that scorecard was, a lot of oranges, some reds, some greens. We were focusing on, the places where we were doing really well, but we weren't systematically applying that to every single thing that we did. And I think coming back to Sarah's point around data, these are lives, these are not numbers. And what we, I think, can do as women leaders is make sure that what gets counted is what matters, and I think, there's an opportunity to think about what are the, quote unquote, indicators that make the difference. And so one of the other things that we're working on is in our community of practice. We also support a community of practice. It's the leaders of those coalitions who are identifying what success means to them and now figuring out how we measure that. And I think that is the place where we can put attention to, because if we align around the measures that matter and we create accountability structures for them, then other people can carry our water, so I'll stop there.
Fantastic response. And I think the next question, maybe I will direct it to you, Alice. It has to do with, how do you, what kind of techniques or strategies do you use to change community attitude towards better women's health in general, and also to get buy-in from the Ugandan government? So both from your policymakers and the community perspective, if you can respond to that from your personal experience.
So the whole thing rotates around the statistics or the numbers. I have not been so much privileged to use a lot of statistics nationally, but the numbers and the experiences. So I have found the power of, there is power in collective voice, the power of collective voice, the collective voice of the very vulnerable women, the very population that I stand for. Mobilizing them, bringing them together, listening to them carefully. And after listening to them, working with them to find solutions to those very things that are pressing them. I have found that a very, very wonderful strategy. These women, many of them may have not gone to school, like the case of Uganda, but these women are very knowledgeable. These women are smart. These mothers in the community, they are smart. They have solutions to some of their problems. And after we have solved those problems, working with them strategies to cause change. Again, these very women have smart solutions on what they can do to cause change. I take, for example, in 2005, after we had supported women for repair, and the fistulas were 95% corrected, they were corrected. But they kept coming back to us. They reported not being happy. Many had not reunited or gone back to their families. They were feeling helpless and disempowered as human beings, to live as human beings. We brought them together and asked them, what can you do? We don't have resources, we don't have funds. What can you do? And they said they want to do some economic activity to generate personal income. And we said, how do we find the money? Then some of them said, we want to talk about these issues. We want to be used in the media as sources of stories in those media platforms. And that is how we introduced music, dance, and drama. Mm-hmm. They said, you see, I know how to sing. That's all I have. I can talk, I can dance. And drama indeed is a core pillar of our community programs. Mm-hmm. So I found that very, very helpful. Then the other one is collaboration, the power of collaboration. Building consortiums, working on important issues of priority as a team. It's not easy. It's not easy to get civil society organization, private sectors coming together, rallying behind the same issue. But I found it working. Even cultural institutions ran rallies, national level rallies, to raise money to support this great cause. Cultural leaders, religious leaders, through dialogues, bringing information, giving them the numbers, bringing them, encouraging them to dialogue. So we have invested a lot in community dialogue with strategic leaders, dialogue with strategic stakeholders. And then lastly, what we have also found and working very well so far for us is using the very, very ladies as change agents, not only at community level, but even at national level, using the community solidarity groups as change agents. They themselves, in many instances, have acted as sources of finance for their income generating activities. And when they are busy with income generating activities, they generate personal incomes, which they have used to fund their advocacy activities in the community. So what we do as an organization initially is to empower them, to invest in empowering them, training them, equipping them with skills to be able to do the things they want to do to cause change in their communities.
Thank you, Alice. I really appreciate that. And I sense that knowing you, Sarah, a lot of the things that Alice just said pretty much resonates with you because you work in very similar models of community engagement and leveraging the power of communities. It kind of reminds me what all the three of you are saying with coalitions and collaborations is the saying there's an Ethiopian proverb that says, when spider webs unite, it can tie up a lion. And I have always really appreciated the deep meaning behind that, and that there is a power in collective voices and platforms. And there's one last question I was hoping we can get to, maybe if you can do it in 1 minute, Mariana, that way we can end with some of the announcement of your programming as well. The question is, U.S. has one of the worst maternal outcomes in the developed world, and yet we spend more on healthcare than any other nation in the world, which is very true. And this speaker is saying is that people don't seem to understand this very much, and what should we be doing to get the message across? And I know you've done a lot of work on this as well, US side. Is there one or two advice that you have for people?
I think the short answer, is inequity and systemic, discrimination, systemic racism. And I mentioned before that maternal health is a vital sign, not just of our health systems, but of our societies. And where we see inequities, it's reflected in maternal health. The United States has huge inequities along racial lines. And until we address the systemic racism in our system and the ability of women to access high quality care, once they are in the healthcare system, the same things are happening. Healthcare providers are not listening to them. They are not, they don't believe what they say. They don't act and respond on it. And then, that's what leads to the deaths. And so I think that, for all of our work, we talked about coalitions, and, I feel African women, like, if you want something to get done, call on an African woman, because the strength and the conviction, that I hear with Alice and Sarah, if we put our resources, in their hands, there's nothing that can't happen. But around that question is these coalitions and communities should cross borders, because the same issues that are happening in communities on the continent are happening, in my backyard in Brooklyn here. And I think that there's huge power in bringing not just these voices together, but in mobilizing collective action around these very similar solutions, because the root causes, as Sarah said, at the end of the day, are the conditions that women live their lives. And unfortunately, too many of those conditions are beset by systemic inequity.
Thank you. Thank you so much. That is a great way to end this panel discussion. I can't thank you enough for this fantastic conversation. There's a lot packed in here. I wanted to just let viewers know that we are now sharing a call to action from our center on the screen. As we shared with you, we had this global engagement funds that we awarded this year. We want to do this on a regular basis, and you can support future projects like those and other work by supporting our center, and the link is here on the screen. And also on the slide, you will see a few ways to connect and get involved with our panelist organizations as well. And this information will also be sent to you in a follow-up email. The meeting recordings for this will also be on our website as well. So please stay connected and stay engaged and keep doing the work that you're doing locally to elevate maternal health. Every voice counts, as you've heard from the panel discussion today. And I just want to thank our panelists, our audience members for joining us, and also our partners in the WHEEL collaboration for putting together this webinar series. This one is the third of the series on International Women's Day, and we appreciate all of you. And thank you so much.
Thank you for having us. Thank you.
Thank you.